Ciao mondo, hello world, hola mundo, hello monde, konnichiwa, ni hao, namaste. I'm here with my friend John Kellum at the International Vicenza Conference on AKI, CRRT, and extracorporeal organ support. And we had the privilege to hear from the main author the results of the TIGRIS trial. And so without any further ado, I would like to ask John to briefly describe this Bayesian methodology and the main result, and what is the impact that you expect to have in the clinical practice from the TIGRIS?
Briefly.
Briefly.
Yeah, so unlike standard frequentist statistics that everyone is familiar with, Bayesian analysis is more like how clinicians think, right? We start with what we know, and then we add new data, and then we come up with a posterior understanding of what we want to know. In this case, it is whether we can reduce mortality with an intervention such as removal of endotoxin using PMX. And we had a very scientific prior data, which was data that came from a prior trial that we used to design the new trial, same criteria, same sites largely, and really same everything. And we then conducted the new trial, which is the new data. We added the new data to the prior using the Bayesian analysis, and we generated a positive posterior predictive probability of mortality at 28 days that was greater than 95.3% and at 90 days of 99.4%. And what that really means is that unlike a p-value, which tells you what's the likelihood of it being reproducible under multiple, running the same trial again and again, we can say exactly what the probability and the credible interval around it is for the thing you're interested in, which is mortality at 28 and 90 days.
Fantastic. I have to take credit that one of the first trial on this thing was the EUPHAS trial that we did in Vicenza many years ago. Of course, it was a small population. It was different time where statistical design was different and many other aspects. But I was struck from the beginning from the improvement of the SOFA score and the quality of health of these patients after 2 treatments. So what is the impact that you think this study will have in daily practice?
Yeah, so I think that there have been multiple guidelines published based on integrating the data that you generated many years ago with subsequent data, and really there's been very variable results based on variable enrollment criteria. Your study had a baseline mortality, if I remember correctly, in the control group that was above 50%,
Yeah.
Which is very similar to what we enrolled, so a very high severity group, whereas there have been other studies which have enrolled patients with much lower severity and failed to demonstrate benefit. So I think it's hard, obviously, you can't really do that in prospect. You can't say, wow, I'm going to enroll patients that have a 40% mortality rate, because you don't know what their mortality rate is, right? So you could say, I'm going to enroll patients that have demonstrably high levels of endotoxin, and in our case, demonstrably high levels of organ dysfunction. You mentioned the SOFA score, we use that, or the MOD score. That identifies the population that's at high risk of death, and we call that predictive enrichment. And we also used prognostic enrichment to identify patients likely to respond to the intervention, which in this case is removal of endotoxin.
Fine. So I think that this would be one of the first steps towards the wall of evidence around this type of therapy and possibly other type of therapies in the future. We will see very much physicians that today are not certain, probably moving more towards a kind of willingness or propensity to apply this therapy. And as we apply largely the therapy, we will probably see the benefit in daily observation, and we will also learn how to use it in the most proper way. So with this, thank you very much for joining today Cappuccino with the TIGRIS results from John Kellum from Vicenza, Italy, at the course on critical care nephrology. Excellent.
Excellent.